Let me. Great. Thank you, Bintaji, for starting the recording. Namaste. Welcome to everybody to the 25th webinar of the Nepal Mental Health Research Webinar Series, जुन चाहिँ jointly TPO Nepal र George Washington University ले organize गरेको हो. हाम्रो 25th webinar is on understanding mental health related structural stigma and discrimination in Nepal through scoping review of health and social policies. अनि हाम्रो आजको speaker हुनुहुन्छ दृष्टि गुरुङ. Um, we will get to the webinar in a second, the content of the webinar in a second. But before that, we have a couple of quick things. जसको बारेमा हामीले सबैजनालाई वेबिनारको अगाडि जहिले पनि भन्छौँ. The first thing is that the webinar is recorded. तपाईहरूले देखिराख्नु भएको छ कि हाम्रो webinar record भइरहेको छ. That is so that we can share the recording with everybody उहाँहरूको futureको knowledgeको लागि. By staying on in this webinar, हामीले चाहिँ तपाईहरूले हामीलाई रेकर्डिङको लागि कन्सेन्ट दिनुभएको भनी मान्छौँ. हाम्रो वेबिनारको स्ट्रक्चर कस्तो छ भन्दाखेरि for the first few minutes, as I'm doing right now, हामीले हाम्रो वेबिनारको बारेमा भन्छौँ, what do we do in this webinar भनेर भन्छौँ. And after that, let's say हामीले हाम्रो स्पिकरलाई पनि इन्ट्रोड्युस गरिसकेपछि we go on into our webinar. हाम्रो स्पिकर has roughly 15 minutes to present उहाँको टपिकमा. त्यसपछि 10 to 15 minutes open discussion को लागि हुन्छ. त्यतिखेर तपाईहरूले either chat box मा आफ्नो questions राखेर अथवा आफ्नो hand raise गरेर questions हाम्रो स्पिकरलाई राख्न सक्नुहुन्छ. After that, हामीले लगभग 15 to 20 minutes चाहिँ breakout room को लागि breakout discussions को लागि छुट्याएको हुन्छौँ. जसमा हामीलाई हाम्रो स्पिकरले प्रोभाइड गर्नुभएको क्वेसन्सहरू छ वेबिनारको जुन उहाँको टपिक छ त्यसमा रहेर उहाँले दिनुभएको हामीलाई क्वेसन्सहरू हुन्छ. त्यो क्वेसन्समा चाहिँ नि हाम्रो टिम मेम्बर्स एज को फेसिलिटेटर्स भएर हामीले त्यो रुमहरूमा त्यो क्वेसन्सहरूमाथि छलफल गर्छौँ. The goal of the webinar breakout sessions is to get us all really talking on things that matter to us with respect to the question जुन चाहिँ हाम्रो वेबिनारको स्पिकरले प्रोभाइड गर्नुभएको हुन्छ. हाम्रो को-मोडरेटर्समा म हुन्छु. मेरो नाम रितिका हो. I did not introduce myself in the beginning. I hope by this point I'm a pretty known face to those of us जो चाहिँ हाम्रो वेबिनार सिरिजमा आउनुहुन्छ. साथसाथै बिन्ताजी who's usually हाम्रो moderator, उहाँ पनि हुनुहुन्छ एउटा co-facilitator, and Drishti Guru, our speaker, will be the third co-facilitator for the breakout rooms. With that, हाम्रो last 5 minutes चाहिँ usually हाम्रो breakout room सकिसकेपछि everybody returns to the main room. And हाम्रो speaker will have a couple of other slides to basically provide her inputs on breakout questions. जुन breakout session को questions हरू थियो त्यसमा उहाँहरूले आफ्नो थप input दिनुहुन्छ last 5 minutes of the webinar मा. So please stay with us until the end because there's always something to learn till the very end of this webinar. अर्को एउटा reminder, हाम्रो feedback forms. We always send out feedback forms हाम्रो chatमा राख्छौँ हामी हाम्रो webinarको endतिर. The goal of the feedback form is to make sure that we are very people oriented. तपाईहरूबाट नै हाम्रो webinarमा के improve हुन सक्छ र what did you really like about our webinars so that we can make our webinars even better भनेर चाहिँ हामीले feedback form पठाउँछौँ. Please, we request everybody to fill those out. Just a reminder, हाम्रो webinars monthly हुन्छ. Third week of every English month मा हामीले हाम्रो webinars गर्ने गर्छौँ. Some breaks every now and then. तर we always send out invitation emails at the very beginning of the month so that everybody can register in advance and put the slot on the calendar to make sure that you don't miss the event. But to just let you know, usually third week of every English month मा चाहिँ हाम्रो webinar हुने गर्दछ. Now, without further ado, I would like to request Dr. Soharda Rai, who is a research scientist at George Washington University, to introduce our speaker for today.
Thanks, Ritika, and hi everyone. It's my pleasure to introduce Drishti Guru, a very close friend of mine over the last 20 years. Fun fact, we went to high school and undergrad together and also now work together. So for more formal introduction, Drishti is the co-investigator and project manager for the RECEP trial and the country lead for the Indigo project at TPO Nepal, or Transcultural Psychosocial Organization. She did her MSc in Global Mental Health from King's College London and London School of Hygiene and Tropical Medicine, and she's currently a PhD candidate at King's College London with a focus on developing measurement framework for mental health related structural stigma and low and middle income countries. She has a keen interest in understanding and reducing discrimination within health systems, which has led to collaboration and co-production with people with lived experiences of mental health conditions. She recently worked as a commissioner on the Lancet Commission on Ending Stigma and Discrimination in Mental Health and chaired the launch event of Commission Report, which was hosted by the World Health Organization, and also after battling all things that she had in Upper Mustang. Her work not only focuses on promoting inclusivity within mental health systems, but also in other areas of global health, such as addressing the gender disparities within the health and research workforce. And her contributions and work as an early career researcher, she was awarded the Visionary Innovators Shaping Tomorrow's Advancement, or VISTA Award, by the National Institute of Mental Health, US, during the NIMH Global Mental Health Conference in October 2023. So with this, I want to hand over to Drishti, and I'm very excited to hear from her. All right, so over to you, Drishti.
Thank you, Sohardia, for that wonderful introduction. Okay, let me share my screen. Ritika, is this good?
This is great. Thank you, Drishti.
Okay. All right. Good evening, everyone, and thank you so much for joining us today in this 25th webinar. And as Ritika already mentioned, in this webinar, I'm going to present on understanding mental health related structural stigma and discrimination in Nepal through scoping review of health and social policies. In the beginning, I'm going to talk briefly about what structural stigma and discrimination is, and then go on to talk about how we did this scoping review of health and social policies. I'm then going to highlight what were the key findings from the policy review. And later on, during the breakout sessions, we're going to discuss on different ways that we could measure structural stigma and discriminations besides policy review, and also key recommendations that could be made based on the policy gaps that were identified through the policy review. So let's move on. So mental health, what is mental health related stigma? Mental health related stigma is when we see people with lived experiences of mental health conditions as being different and treat them differently, or when people with lived experiences view themselves as being different. So the first one is also called the structural stigma, the second one also called self-stigma. However, many times stigma, rather than being enacted by other people or by people with lived experiences themselves, takes place within a structure or systems. And we can see that when there are discriminatory policies or laws against people with lived experiences. We can see it also in the allocation of resources, such as allocation of fundings, and in the quality of care provided. And unlike the self-stigma and interpersonal stigma, in the structural stigma and discrimination, we cannot blame or hold any one individual accountable for this stigma enacted. Hence, structural stigma and discrimination, also known as systemic or institutional stigma, are the societal level conditions, cultural norms, and institutional policies that constrain the opportunities, resources, and well-being of the stigmatized. In short, structural stigma and discrimination in mental health are the policies and practices that causes intentional or unintentional disadvantages to people with lived experiences of mental health conditions. So to look at the structural stigma and discrimination in Nepal, we did a scoping review and synthesis of health and social policies. So we looked at various policy documents such as laws, legislations, policies, directives, program strategies, etc., that were drafted and passed by the institutions and bodies under the government of Nepal that were made available either in English and or in Nepali. And for the sake of feasibility, we only looked at documents that were drafted or amended after 2010. Here's the Prisma flowchart for the scoping review. So you can see that we identified the policy documents through various websites, such as the Law Commission website, the Ministry of Health and Population website, and Ministry of Women, Children, and Social Welfare website. We also reached out to numerous policy stakeholders from the government and non-government institutions. And after going through the screening and eligibility processes, we finally included 89 social and health policies. So what were the key findings? So let me begin by from the positive findings that we saw in the results. First, we saw that there was increased inclusion of mental health agenda over the years, especially in policies that were drafted after 2015, mainly in the social welfare policies that targeted people from marginalized and vulnerable communities or those affected by disasters. We also saw notable changes in language and words used. For example, in the archaic policies, we have noticed various discriminatory terminologies such as bola or pagal, mad and insane, and provisions such as imprisonment of people with mental health conditions until they become normal after treatment. So these sort of discriminatory policies to some extent have been amended in the current policies. And we also saw increased attention given to integrating mental health in primary healthcare and basic healthcare services, taking into consideration the treatment gap in mental health care in Nepal. So those were the positive changes that we saw. However, there were a lot of policy gaps, some of which I'm going to highlight here. The first thing is the terminologies or names used in the policy document. So some of you might have heard of this quote, "What's in a name, that which we call a rose by any other name would smell just as sweet." And here Shakespeare meant that if you call a rose by any other name, it would still smell as a rose. However, I have a bone to pick with Shakespeare because, as we all know, mental health stigma in most cases are enacted by labeling. And we saw a lot of that in the policy document. So we looked at the English translated document that were made available in the Law Commission website, but we also then went on to look at the terminologies in Nepali, official Nepali documents. And we saw some labeling terminologies such as use of words as insane, mad, lunatics, person who's mentally unsound, mentally sick, or mentally abnormal, some vague or imprecise languages such as mental unsoundness, drug abuse, mentally ill, mental health as conditions as afflictions such as suffering from mental illness or mental disease, terminologies that implied incompetence such as mentally incapable, mentally incompetent, or incapacitated. So what we noticed that there was no policy documents that formally provided definitions for a lot of terminologies that they used in these documents, such as mental health conditions, mental disorders, psychosocial problems, etc. Most of these social and civil policy documents used the word of unsound mind or hosteganma naraheku to indicate people with lived experiences. And the National Penal Code Act 2017 defined the of unsound mind as the condition of being incapable due to physical and mental ill health of knowing the act done by oneself in general understanding and consequences thereof. And here, although this has moved way forward than the past archaic terminologies of bola or pagal or the pagal, however, we can see that even the use of unsound mind could be discriminatory. The act relating to rights of persons with disabilities, or the Disability Act, as I'm going to refer since it's a mouthful. We all know that it has included mental and psychosocial disability as one of the categories of disabilities. And they have defined mental or psychosocial disability as the inability to behave in accordance with age and situation, delay in intellectual learning due to problems in performing intellectual activities, like problems arising in the brain and mental parts, and awareness, orientation, alertness, memory, language, and calculation. So even in the Disability Act, which normally we would refer to as we do not have our own Mental Health Act, here the definition implies more to the problems arising in brain and mental parts, which again could be discriminatory in itself. There were a lot of inconsistencies that were seen within and between policies that restricted the rights of people with lived experiences. So we all know the Constitution and a lot of other acts, such as the Disability Act or the Public Health Act. So these sort of acts prevents any sorts of discrimination with regard to any health conditions. However, in a lot of other acts, we did find special provisions that were made that address people with lived experiences, such as the Police Act permits taking charge of lunatics unable to care of themselves as part of their duties. Some of the policies, such as the Civil Service Act or Local Level Election Act, disqualified a person from holding a position or candidacy if they were found to be insane or of unsound mind. The National Civil Code Act, drafted in 2017, prohibits persons with mental health conditions, among other conditions, from marrying. There was also so here you can see a lot of discrimination in terms of what was mentioned or the provisions that were mentioned within the act. However, we also looked at the notable silences or provisions that were not made, although they should have. So for example, a lot of the health and mental health policy documents did not have provisions for people with substance use disorders, because in Nepal, it could be that substance use disorders besides alcohol use is considered to be illegal. Some other policy gaps that were seen were inadequate integration of mental health agenda within the broader national policy framework, which is in the mental health strategy and action plan. However, we did not see that as there were noticeable silence in integration within social security, employment, education, housing, poverty, sexual reproductive health policies. Also, one of the biggest gaps that we saw was there were lack of reliable financing mechanisms for the implementation of strategies and action plans. So we looked at the operational guidelines that mentions allocation of resources for various programs, including mental health. And these were not reflective of the strategies and plans that were outlined. There weren't policies that address any like cost-effective interventions, sustainable budget planning, or identification of funding sources. And another key gap that we saw was deviation of local policies from international protocols and conventions. The key ones that addresses people with mental health conditions are the UNCRPD, or UN's Convention on the Rights of People with Disabilities, and the Universal Declaration of Rights. So in a lot of local policies, legal capacity of an individual was undermined based on incompetence. So they were not so their consent was not warranted if they were deemed to be incompetent. Lack of provision against any involuntary or forced treatments. Also, there were no provisions on assisted decision-making that safeguarded the rights of persons with disabilities. And yeah, so this is just a brief overview of what we found from the policy review. Thank you so much for listening. And I think, Ritika, I'll hand it over to you for any Q&A.
Thank you so much, Drishti, for a wonderful, if a slightly alarming presentation. Um, this is wonderful. I cannot believe the amount of work that went into it, and I have nothing but appreciation to you for bringing this matter into light. Um, I know that we have a question or two already. Just want to take this opportunity to say that for the next 15 minutes or so, we can dive deeper into what Drishti has just presented to all of us. भर्खर दृष्टिले हामीलाई भन्नुभएको कुराहरूमा हामीलाई धेरै क्वेसन्स हुनसक्छ, कौतूहलता हुनसक्छ, त्यो सबै सोध्ने मौका यही हो किनकि दृष्टि हामीसँग हुनुहुन्छ नेक्स्ट 15 मिनट्सको लागि. Feel free to either raise your hand to ask a question. अहिलेको लागि चाहिँ म च्याटमा आएको जे क्वेसन्सहरू छ त्यसमा केही टाइम बिताउन चाहन्छु. सरजु सिंह राई sorry उहाँको क्वेसन छ. Oftentimes, people with lived experiences are also excluded from joining workforce due to structural stigma. My question is, if the policies from Ministry of Labor, Employment and Social Security was also assessed. Oh, whether policies from Ministry of Labor, Employment and Social Security were also assessed? If yes, did you find anything noteworthy? If not, is it something that you think should be taken into consideration? Drishti.
Thank you so much for the question, Sarjuji. Definitely, हामीले चाहिँ so various policies-हरु include गर्दाखेरि चाहिँ employment, social security related policies-हरु पनि हेरेको थियौं. And another alarming, and I mentioned this briefly in my presentation as well. So mental health चाहिँ यस्तो खालको social broader policy framework-मा चाहिँ address भएको छैन. So employment-मा clause provisions that discrimination cannot be made based on any caste, ethnicity, etc. However, we did find notable silence when it came to disabilities or mental health conditions. Social security really addressed भएको छैन. And in a lot of like civil service jobs तिनीहरूमा चाहिँ provision नै छ कि if a person of unsound mind भयो भने चाहिँ they need to leave the job भन्ने provisions-हरु पनि छ. So yeah, so we did find that.
Dr. Vinod Paudilko, your question छ. What about marriage and severe mental disorder and law of Nepal?
Yep, so Nepal Penal Act, Code Muliki Ain, which was redrafted recently in 2017, there is a provision that people, amongst many other health conditions, so mental health, oral health conditions are been listed. So this marriage को लागि eligible हुँदैन भनेर लेखिएको चाहिँ छ. And that in itself is again discriminatory.
Thank you, Drishti. Do we have any other questions? In the meantime, we also have a brilliant paper जुन चाहिँ दृष्टिले भनिसक्नुभयो कि उहाँको पेपरमा नै आजको presentation based हो भनेर. I'm going to link the paper in हाम्रो chat if that's okay, Drishti. I think open access नै छ. So everybody whose curiosity has been jump-started by this can further read the paper, and हामीले जब हाम्रो materials, webinar materials पठाउँछ तब हामीले त्यो paper पनि पठाउँछ. Another question from Renu. As researchers, we directly jump into doing work, example, implementing stigma reduction package and come up with recommendations for policymakers. So what was your motivation to first look into policy documents beforehand?
Thank you, Renu, for that question. So this brings me to the beginning of my PhD, where I had to justify my topic. And so my interest in structural stigma was just that. There is also mental health related stigma interventions or research or intervention design गर्दाखेरि चाहिँ जहिले पनि interpersonal stigma or self stigma हरूमा focus भइरहेको हुन्छ. And there aren't much literature out there, or there isn't much done around structural stigma. However, we know that there is also your interpersonal self-stigma, it's driven by structural stigma and systemic level stigma. So त्यो कारणले नै to understand more about structural stigma, what's there, that's the whole part of my PhD. And so I took this project as part of my PhD, basically.
Just to let everybody know, I have put in the article in our chat as well. हाम्रो यो भर्खर पुरा गरिरहेको पेपर जुन दृष्टिले धेरै मेहनत गरेर रेडी गर्नुभएको छ, it's there for anybody who is interested. Please feel free to go ahead and check this out. Do we have any other questions, comments, compliments, any curiosities?
Compliments.
I genuinely think हामीले हाम्रो यो capacity building को पार्टमा एउटा motivating र complimenting पनि राख्नु पर्छ, किनभने webinars are not just about like, but then did you miss this, for example, or यसको further implication के हो? It's also about appreciating the work that has gone into this until now. So another question. What is your step to eliminate stigma related to mental health in context of Nepal? Heavy question, Drishti.
I know. So by stigma, I'm not sure if you mean like any sort of stigma. So let me get into detail of what we're doing right now. So currently हामीले चाहिँ primary healthcare workersहरूको stigma reduction को लागि एउटा intervention package चाहिँ try as a cluster randomized control trial implement गरिरहेको छौँ. त्यो सँगसँगै another project that I'm part of, Indigo, we're also looking into proof of concepts of various interventions at different levels, such as community, at primary healthcare again, and at the psychiatrist level. यो चाहिँ again त्यही interpersonal stigma र anticipated self stigmaहरूलाई address गर्नुको लागि यो interventionsहरू रहेको छ. अहिलेको लागि structural stigma address गर्नुको लागि we haven't come up with anything. Hopefully by the end of my PhD I will be able to come up with something for that.
Great. Thank you, Drishti. We have one final question, after which we will move on to our breakout rooms. In our experience, there are also questions after breakout rooms. And as I just mentioned, हाम्रो presenter, Drishti, has a couple of slides to sort of like synthesize the entire discussion. So I would encourage everybody to stay on until the end. Torju Singh has one final question from her side. Will your PhD research also look into the experiences of people with lived experiences and their first-hand account of how structural stigma has affected their lives? It would be nice to highlight how these discriminatory policies are affecting people affected.
Yep. So thanks, Sarjuji. Definitely when it comes to stigma or any mental health related research or interventions, we do highlight the involvement of people with lived experiences and getting their voices heard. And so even in my project, which I will be talking more about after our breakout session. So we have included the experiences of people with lived experiences regarding structural stigma as well. And I am in the process of conducting more studies around that as well.
Thanks, Drishti. Okay, final question before we go into our breakout rooms. This was a really insightful paper. Would love to read the whole paper. Anjiji, please do. म सबैजनालाई एकदम encourage गर्छु. As I just mentioned, I've already put it in the chat. अनि हामीले हाम्रो webinar materialसँग पनि share गर्छौँ यो. So please पढ्नु होला. Based on your review, where are we as a nation in the field of mental health, and what are the recommendations you would give? I would also love to know if you have any recommendations for junior researchers.
Wow. यसको लागि त छुट्टै वेबिनारै राख्नुपर्छ जस्तो छ. Um, it's at an I would say it's at an interesting stage. Mental health as a field in Nepal, it's growing. Um, Especially stakeholdersहरूको इन्ट्रेस्ट फन्डिङहरू बढी नै रहेको छ मेन्टल हेल्थमा and which was also seen in our policy review that over the years policies-हरूमा पनि थप provisions-हरू तिनीहरू psychosocial mental health-मा अलिक बढी हुँदै आइरहेकोहरू पनि देखिरहेको छ. So yeah, I would say it's in very early but interesting stage. Any recommendations for junior researchers? So many. Um, um, I don't think we have time to address that right now. Sorry, Anjuji. But we do hold like some networking events or like other events from MHRN from time to time. So I would suggest that you look out for that and please do join. And we can chat then. Or feel free to email me anytime.
Yes. Thank you, Drishti. Thank you, team. Thank you, everybody, for a wonderful question answer session. अब हामी discussion rooms मा जान्छौँ. त्यसपछि फेरि पनि we will come back to the main room. We have 3 discussion rooms. हरेक discussion room will have a co-moderator. म एउटा रूममा, दृष्टि अर्कोमा र बिन्ताजी अर्को रूममा. Every discussion room will have one question. त्यो क्वेसनमा तपाईहरुले मजाले डिस्कस गर्नु होला. Please think of this as an opportunity to get your voices heard, get your opinions across, and to ask any questions that you want as well. 13 minutes मा breakout room फै बन्द भएर we will तपाईहरुले 30 seconds को countdown पाउनुहुन्छ. Then we will all come back to the main room and we will continue with our discussion. Bintaji, a request to please pause the recording. नभए यतिकै blank आउँछ. I'm opening all the discussion.
छ सबको चाहिँ अलिक क्लियरली डेफिनेसनहरू क्याटेगोरिजहरू राख्दै चाहिँ यो यसरी छ भन्ने भयो भने चाहिँ अरू सोसाइटल लेभलमा हुने स्टिग्माहरू पनि कम हुँदै जान्छ अनि स्ट्रक्चरल हेल्थ सिस्टममा पनि त्यही अनुसारको अन्डरस्ट्यान्डिङ हुन्छ होला हेल्थ सिस्टम लेभलमा पनि भन्ने भयो. अनि अर्को रेकमेन्डेसन भनेको जस्तो इन्टरभेन्सनको ले जस्तो अहिले हामीले इन्टरभेन्सन गरिरहेछौँ जस्तो पिएचडीको जस्तो रिसर्च पेपरको उहाँले कुरा गर्नुभयो त्यसरी नै इन्टरभेन्सनबाट यो कुराहरू चाहिँ एकदमै अलार्मिङ छ है भनेर त्यो देखाउँदै जाने एभिडेन्सेसहरू देखाउँदै गयो भने चाहिँ पोलिसीमा कोही मान्छेले एडभोकेट गर्यो फोकल पर्सनले फोकस दियो भने त पोलिसी लेभलमा पनि जसरी पनि जानै पर्ने हुन्छ भन्ने खालको रेकमेन्डेसन भयो. यस्तै छ अरू भनेको त्यही फोकल पर्सनहरूको अलिकति अलर्ट हुने फोकल पर्सन मेन्टल हेल्थ फोकल पर्सन जुन हाम्रो म्युनिसिपालिटी लेभलमा हुनुहुन्छ उहाँहरूले पनि अलिकति फोकस दिनुभयो र प्रोग्राम इन्टरभेन्सनमा चाहिँ आफ्नो पनि केही एफोर्ट्सहरू दिनुभयो भने चाहिँ त्यसले पोलिसी ग्याप अलिकति रिड्युस गर्छ भन्ने छ. यति नै छ सबै यही वरिपरि नै इभल्भ भइरहेको छ यही नै हो. थ्याङ्क यू.
Thank you very much, Bintaji. Policy level ko recommendation भयो. Healthcare recommendation लाई चाहिँ if you want to feel better, join हाम्रो mental health webinars हैन त. And our discussions भनेर पनि थाहा भयो. हाम्रो रूममा चाहिँ unfortunately discussion अलिकति limited भयो because of technical issues. I kept getting pulled back to the main room. We will have to discuss this and troubleshoot. Bintaji, Bhavanaji, thank you very much for तपाईँको help with moderating the discussion for that. We had several substantial discussions in our room. एउटा मेन आएको जुन बिन्ताजीहरूको रूममा पनि आएकै थियो. हाम्रो breakout session को discussion was more about understanding and measuring structural stigma. बिन्ताजीहरूको चाहिँ नि key recommendations जुन यो understanding आइसकेको छ त्यसपछिको key recommendations हरू थियो. हाम्रोमा चाहिँ mental health को यो structural stigma बुझ्नुलाई चाहिँ service users, people with lived experience को inclusion नभई हुन्न भन्ने एउटा main theme that came across very well. अनि अर्को एउटा कुरा that also came across very well was understanding the positionality of हाम्रो subjects. किनभने कसैलाई पनि मेन्टल हेल्थ इश्यूज अथवा कुनै पनि इश्यूज आइसोलेसनमा हुँदैन. उहाँहरूको क्लासदेखि लिएर उहाँहरूको सोशल सिचुएसनिङले पनि एकदमै अन्डरस्ट्यान्डिङको लागि अफेक्ट गर्छ भन्ने कुरा आएको थियो. अनि अर्को एउटा एकदमै इम्पोर्टेन्ट कुरा आएको भनेको चाहिँ नि pathways to treatment. मान्छेले मेन्टल हेल्थ स्पेसलिस्टकोमा जानु नगएर किन ट्रेडिसनल हेल्थ केयर वर्कर्सहरूकोमा जानु खोज्छ, किन फिजिसियन्सहरूकोमा जानु खोज्छ, र त्यसमा चाहिँ इनहेरेन्ट स्टिग्मा कति लुकेको छ त्यसलाई पनि केलाउनु जरुरी छ भन्ने कुरा आयो। हाम्रो एकजना साथीले एउटा एनएचआरसीको 2020मा अन्डरस्ट्यान्डिङ मेन्टल हेल्थ कन्टेक्स्ट इन नेपाल भनेर एउटा सर्वेको आउटपुट छ भनेर पनि इन्फर्मेसन सेयर गर्नुभएको छ। सक्नुहुन्छ भने हाम्रो एमएचआरएन नेटवर्कमा प्लिज त्यो पेपर इमेल गरिदिनु होला, अनि हामी सबैजनालाई डिसेमिनेट गरिदिन्छौँ। या थ्याङ्क यू फर द डिस्कसन। दृष्टि, ओभर टु यु। तपाईँले आफ्नो ब्रेकआउट रुमको ओभरभ्यू भनेर तपाईँको आफ्नो स्लाइड्समा पनि जान सक्नुहुन्छ।
Thank you so much, Ritika and Bintaji, for facilitating that discussion. So again, हाम्रो ग्रुपमा चाहिँ रितिकाको जस्तै अलिक डिफिकल्ट क्वेसन थियो। स्ट्रक्चरल स्टिग्मालाई कसरी मेजर गर्न सकिन्छ भनेर मेरो 5 वर्ष बितिसक्यो यसमै। त्यही नै डिस्कस गर्न खोजिरहेको थियौँ, तर इन्ट्रेस्टिङ कुराहरू एन्ड काइन्ड अफ सिमिलर टु वाट यु गाइज टक्ड अबाउट. So again, the first thing that came up was involvement of people with lived experiences. किनभने उहाँहरूले एक्सपिरियन्स गरेको हो, सो उहाँहरूबाट पनि थाहा हुनुपर्छ, थाहा पाउन सकिन्छ भन्ने कुराहरू. सो मोर इन्टरभ्युइङ people with lived experiences, त्यो कुराहरू आएको थियो. त्यस्तै गरी इन्स्टिट्युसनल प्र्याक्टिसेसहरू तिनीहरू पनि हेर्न सकिन्छ. एन्ड आई ब्रट अप दि WHO's क्वालिटी राइट्स टुल किट्स, जसमा चाहिँ जसबाट चाहिँ डिस्क्रिमिनेसन इन्स्टिट्युसनल लेभलमा भइरहेको छ कि छैन हेर्न सकिन्छ भन्ने कुराहरू थियो. अर्को आएको कुरा भनेको इम्प्लोयर्सहरूको मा पनि एसेसमेन्ट गर्न सकिन्छ, जस्तो एसेसमेन्ट फर्म्सहरू क्रिएट गरेर इम्प्लोयर्सहरूले कसरी उनीहरूले मेन्टल हेल्थको कुराहरू एड्रेस गरेको छ छैन, के भइरहेछ भनेर त्यो पनि एसेस गर्न सकिन्छ भन्ने कुराहरू भइरहेको थियो. अर्को चाहिँ अलिकति पोलिसिजहरू, यो चाहिँ मोर अफ रेकमेन्डेसन्स आई गेस रादर देन हाउ इट क्यान बी मेजर्ड. तर पोलिसिजहरू बनाउँदाखेरि चाहिँ जो भलनरेबल पपुलेसन हुनुहुन्छ, टार्गेट पपुलेसनहरू, उहाँहरूसँग चाहिँ पहिल्यै स्टडीहरू गरेर मात्रै पोलिसी बनाउने, उहाँहरूको इन्भल्भमेन्ट भएर पोलिसीहरू बनाउने कुराहरू पनि आएको थियो. So yeah, so those were the main discussion points that we've had. So let me go ahead and share my screen again. Ritika, देखिन्छ?
देखिन्छ.
Okay. So कति समय बाँकी छ?
हामीसँग 4 मिनट.
यही छ. So over my PhD, this is kind of like a framework that I was building to look into structural stigma and discrimination more. So कुन तरिकाबाट, besides policy review, के तरिकाबाट चाहिँ कुन एरियाबाट चाहिँ हामीले structural stigma and discrimination mental healthमा भइरहेको छ छैन भनेर थाहा पाउन सक्छौँ भन्ने कुराहरूमा मैले चाहिँ डिफ्रेन्ट डोमेन्सहरू क्रिएट गरेको थिएँ. जसमा definitely first one is poor discriminatory legal frameworks and policy environment को कुराहरू छ. अर्को मेन डोमेन भनेको चाहिँ स्टिग्मेटाइजिङ सिस्टम, इन्फ्रास्ट्रक्चर एन्ड रिसोर्सेस. सो अघि मैले कुरा गर्दाखेरि एलोकेसन अफ रिसोर्सेसहरू, वेदर द्याट बी ह्युमन, फाइनेन्स अर अदर्स, त्यसमा पनि डिस्क्रिमिनेसन भइरहेको छ कि छैन त्यसरी पनि हेर्न सकिन्छ. र विदिन अ सिस्टम अर इन्स्टिट्युसन त्यहाँको एग्रिगेट स्टिग्मा एटिट्युड प्र्याक्टिसेस त्यहाँ इन्भल्भ भएको. सो नट जस्ट हेल्थ वर्कर्स, हेल्थ एडमिनिस्ट्रेटर्स, उहाँहरूबाट पनि यो कुराहरू चाहिँ लिन सकिन्छ भन्ने भयो. अर्को भनेको इनइक्विटेबल एन्ड पुवर क्वालिटी अफ केयर. सो कोअर्सिभ केयर इन्स्टिट्युसनबाट भइरहेको छ कि छैन, फ्रेगमेन्टेड केयरहरू छ कि छैन, अथवा पिपल विथ लिड एक्सपिरियन्सेसहरूले एक्सेस टु केयर डिनाइ भइरहेको छ कि छैन, त्यो कुराहरूबाट पनि हामीले एसेस गर्न सक्छौँ भन्ने भयो. र फाइनली पिपल विथ लिभड एक्सपिरियन्सेसहरू आफैबाट पनि उनीहरूले एक्सपिरियन्स गरेको नेगेटिभ उसहरू, जस्तै नेगेटिभ इन्टरेक्सन विथ हेल्थ वर्कर, एडमिनिस्ट्रेटर्स, ल्याक अफ इज अफ एक्सेस को कुराहरू, out of pocket expenses in mental health services more than in other health services, त्यस्तो खालको कुराहरूबाट पनि हामीले चाहिँ structural stigma discrimination छ छैन भनेर हेर्न सक्छौं भन्ने यो चाहिँ अहिले प्रोसेसमै छ. We did a Delphi study on this and I'm coming up with the paper, so please look out for that. The second question was what were the key recommendations? So मैले highlight गरेको key gaps हरु छ. So each को लागि recommendations हरु and kind of like what you guys discussed. So immediate policy revisions को कुराहरु, inclusion of people with lived experiences को कुराहरु, intersectionality हरु highlight गर्ने जुन अघि न भन्यो different social structures हरुमा mental health पनि पढ्दाखेरि चाहिँ intersectionality को कुराहरु पनि आउँछ, त्योहरुलाई पनि highlight गर्ने कुराहरु, feasible funding mechanism को कुराहरु identify गर्ने, policy र action plan मात्र बनाएर चाहिँ भएन, त्यो implement गर्नको लागि funding mechanism के छ भनेर त्यसको पनि study हुनुपर्छ भन्ने कुराहरु. So यो सबै चाहिँ again I have included this within the paper that Ritika put the link to. So if you want to learn more, please do go ahead and read that paper. I think यति भन्दै मैले चाहिँ टुङ्गाउन चाहे. These are my acknowledgements. My supervisors, Graham Thornycroft, Petra Gronholm, advisor Brandon Court, and the collaborators and contributors for the paper that I based this presentation on. And yeah, this is my contact address. Feel free to contact me if you have any questions or anything. Thank you, Ritika. Over to you.
Thank you so much, Rishti. As predicted, हाम्रा केही questions-हरु अहिले आइरहेका छन्. Unfortunately, everybody, we are out of time and we cannot address those right now. तर Rishti has put up her contact information यहाँ, and at the same time, तपाईहरुसँग हाम्रो MHRN को पनि email address छ. Please feel free to write to us if you have any questions, and we will make sure that तपाईहरुलाई हामीले respond गर्छौं भनेर. With this, all I have to say is thank you to our wonderful participants for sticking with us until our 25th webinar. It is quite an achievement. I hope we have all learned something valuable in the process. Thank you for sticking with us. Thank you for being such a collaborative part of it. Also, thank you to Binitaji for being a part of this webinar despite your ill health. So, Dr. Sauhada Rai, thank you for your time and for introducing our speaker. Drishti, thank you so much for this wonderful, wonderful presentation that has made us all think a lot. And I hope this is the start of a conversation that we will continue. हाम्रो ट्विटरमा पनि तपाईहरुले हामीसँग engage गरिराख्न सक्नुहुन्छ, which is something that I encourage. Yeah, thank you everybody. And with this, I will close the webinar. Thank you. Good evening. Good day to everybody. Bye-bye.